Hi, I'm Yuriy Kolesnichenko. I'm the Sonologist from Moscow, Russia, and this is lecture about acute abdomen and the practice of pediatric sonography. Acute abdomen or abdominal pain syndrome includes a large layer of acute diseases manifested clinically by abdominal pain. By the words of some doctors from scrubs to series, the clinic is always right. Of course, it's necessary to specify what exactly should be understood under the term of clinic at the present time. If this concept includes only anamnesis and physical examination, palpation, percussion, auscultation, then this is a stone age. Now it's difficult to imagine the functioning of the clinic without modern instrumental diagnostic methods, in particular imaging modalities, and one of the most accessible imaging modalities is certainly diagnostic ultrasound or sonography. This modality has become so accessible, especially recently thanks to new mobile ultrasound scanners, that even a new term, POCUS, point-of-care ultrasound, has appeared, which some clinicians like to call ultrasound stethoscope. Many different protocols have emerged that describe short ultrasound scan principles for various acute conditions for POCUS provided by clinicians. But we definitely need to understand that POCUS is not a substitute for regular ultrasound, but only an attempt to reduce the burden on ultrasound staff and to a great extent to reduce the expenses of medical institutions, insurance companies, else. Since clinicians do not need to extra pay for POCUS, in contrast to regular ultrasound staff. What we can face when a patient complains of abdominal pain in pediatrics. Of course, the spectrum of acute diagnosis is slightly different in acute abdomen in adult and children. In children, most often we deal with suspicion of acute appendicitis and intestinal thickening. Less often it can be intestinal obstruction of another genesis, for example, hypertrophic biliary stenosis in infants, mesenteric lymphadenitis of pharyngeologists, and necrotic enterocolitis and some other diseases. What we look at ultrasound for an acute abdomen? We examine the entire abdominal cavity, including the kidney, pelvic, stomach, and intestine, looking for free fluid, appendix, dilated bowel loops with pendulum-like peristalsis, target sign, or damage sign, which is common with intestinal intussusception, hyperechoic omental in different parts of abdominal cavity, which may indicate a destructive process. For example, a perforated ulcer, destructive appendicitis, or other. Enlarged lymph nodes and other mass lesion that can occur in other conditions, in particular with traumatic injuries in the abdominal cavity. What we look at ultrasound for an acute abdomen example of imaging. This is intestinal intussusception, target sign, another target sign, intestinal intussusception. Two near target signs, intestinal intussusception, dilated bowel loops, obstruction, mushroom sign, enterocolitis, lymph nodes enlarged, target sign, another whole organ damage sign called pseudokidney sign. This one is gastric ulcer, this one is ascites inside intestine. Another ascite inside intestine and susception, another ascite. This one is vascular abnormalities, phlebectasia, ovarian orthopexia, rupture of ovary, free fluid blood, gestational sac inside the uterus. This is compressed lung at pneumonia with hydrothorax. And this one is mass lession that is omental infarction, tethered fat sign called. This one is hyperechoic omentum around the pseudokidney sign of trauma of intestine loop, hollow organ damage sign, iliac rupture, kidney rupture. For suspected acute appendicitis, we measure appendix diameter, which normally should not exceed 5.5 millimeters. Appendix 6 millimeters or more is noted as enlarged because this is suspicious for acute appendicitis. We also check its rigidity. We compress it with a probe compression test, and if it's not compressed or rigid, then this is also suspicious for acute appendicitis. Sometimes we can see calculi in the lumen of the appendix, appendicular, which are also considered as a sign of acute appendicitis. Sometimes clinicians also ask to measure the wall thickness of the appendix, which in my opinion is not a very informative criterion. We estimate the presence of nearby free fluid and hypoechoic omentitis, which may also indicate acute appendicitis. In other examples, anechoic inflamed appendix and omentum around. Another example, appendix, omentum, appendicular inside the appendix, appendix and omentum, typical periappendicular infiltrate. In other examples, abscess, omentum, periappendicular abscess, appendix, omentum, appendicular, appendix, abscess, omentum. What kind of probes we use? Of course, we use convex probes. They even called abdominal, but not only in pediatrics and not only, especially when searching for the appendix, especially for a normal appendix, we use the high frequency linear probes with frequency about 8 to 10 MHz. Without such probe, it's sometimes almost impossible to find normal appendix. Your diagnosis was not confirmed. This is one of the favorite expressions of some clinicians, and this is only mean that the diagnosis made by the clinicians at specific time did not equal to the diagnosis in our conclusions. In my practice, such moments occurs quite often. For example, in the morning, according to my US conclusion, patient had an acute appendicitis, but with the opinion of the clinician, he hasn't. And in the evening of the same day, after the staff changing, another clinicians came and confirmed my diagnosis. Even more amusing situation can be with intestinal intussusception, which in the case of the straightening within water at enema, were called by clinicians as wrong peristalsis, and if they had to be straightening intussusception by the air at irrigoscopy, then they call it intussusception. In other words, the clinic is always right, and even when it's not right, it is right in its wrong. The 6 mm appendix is about nothing. This phrase was once conveyed to me by a patient from a colleague from a well-known research institute, and this is short sentence from some articles in radiology journal about that 6 mm is criterion for acute appendicitis. This is not appendicitis because there is no leukocytosis. Another wrong sentence. And another article for such clinicians who think so. And in that article, so we can see that 18% of patients with verified appendicitis at surgery did not have leukocytosis. As in my other case, ultrasound is only initial method of visual diagnostics, and clarifying the diagnosis often need computed tomography, magnetic resonance, or other research methods, and some cases from my practice. This is a case of teenager which admitted to emergency department of Children's Hospital and sent for ultrasound with suspicion of appendicitis, and at ultrasound we can see the inflamed appendix, anechoic, surrounded by a hyperechoic omentum. It's classical sign. Another example of acute destructive appendicitis with infiltrate. We can see hyperechoic omentum inside anechoic inflamed appendix. It's a 6-year-old girl. Another example with appendicular infiltrate at newborn 3 weeks old. Classical with appendicular subhepatic location. And this one is intestinal intsusception in 1-year-old child. We can see target sign, classical target sign with lymph nodes inside. The same child after expanding intsusception within air. And we can see intestine loops with thickening wall. It's condition after intsusception. Intestine loops with thickened wall. Another intestinal intsusception, target sign classical, lymph nodes inside, and 4-year-old child. And this is another case, 2-year-old child, practically with no complaints. Came for a second ultrasound scan after 1 month after some drug treatment, and we can see enlarged, dilated loops of intestine with anechoic content and target sign, intestinal intsusception, which causes intestinal obstruction. At previous ultrasound scan, I was suspected Gishkon disease. Another example with enterocolitis, typhlitis ileitis. We can see spasmodic intestinal loops and without content, with thickened walls, and enlarged lymph nodes nearby. Another example, another case, an infant with suspicion of intsusception. We can see pseudokidney sign and target sign. This is the same object in different planes of scanning, and with thickened walls and possible enterocolitis. But as we can see before, it can be as a condition after intsusception, after straightening, expanding of intsusception. Another example of acute appendicitis, 14-year-old teenager with obesity, and obesity is a known problem for ultrasound scanning. But in this case, there is no problem to find the appendicitis. We can see anechoic appendicitis, appendix surrounded by omentum hyperechoic. Everything is clear, as we can say the worse is the better, which means that big appendicitis can be clearly visible even at obesity patient. Another example, acute appendicitis and appendicular, long appendix and appendicular hyperechoic. Okay, another example of appendicitis with appendicular. And this one is abscess in the pelvis, possible periappendicular abscess, can see as fluid unhypoechoic content surrounded by omentum. Another abscess, and this case is interesting because the clinician don't think that this case with appendicitis. Clinician thinks that it's a false positive patient without appendicitis, and even after ultrasound scan with suspicion of appendicitis, clinician don't change his opinion. Another example, a child 8 years old with classical signs of appendicular, periappendicular infiltrate, enlarged appendix surrounded by omentum. It's a patient in the public clinic, and it's this case interesting that there is no pain in the abdomen in the time of ultrasound scan. So the pain was the day before, and now no pain. So clinic not right always. Another example, your diagnosis was not confirmed, and we can see enlarged appendix here in the pelvis, and ultrasound conclusion was about appendicitis, but in the morning, as I told before, one clinician not confirmed my diagnosis, and in the evening, second clinician confirmed my diagnosis. So, another example of a periappendicular abscess, presumably periappendicular abscess at 8 years child. We can see mostly anechoic content, round shape, surrounded by omentum. Another case of appendicitis, and it's interesting because it was the second appendicitis at one child. We can call it the recurrent appendicitis, or the case can call it not trust anyone. This child has papers from another hospital in which was written about appendectomy. But in the surgery at this time was founded another appendicitis, and so we can think in this situation about the appendix duplication or stump appendicitis, something like that. Another case is a gastric ulcer at 4-year-old child with suspicion of acute appendicitis. You can see this hyperechoic linear structure. It's antrum gastric ulcer. And another example with suspicion of intussusception. We can clearly see the ascite inside the intestine, typical echo pattern. Another case of ascariasis intestinal. We can see some tubular structure inside intestine, typical tubular structures, and we can see nearby target sign. So it's intussusception and ascariasis in the same patient. Another case of intestinal ascariasis. And the child 2 years old with pain vomiting. Another case, it's a trauma case. There's trauma of the anterior abdominal wall. The patient came with suspicion of appendicitis, but at the second ultrasound I can see that some kind of mass lession. You can see it here, tethered fat sign. It's infection of omentum. In another case, it's ovarian apoplexia, rupture of ovary. We can see a lot of free fluid here in the pelvis. We can see the altered ovary structure, gyparechoic ovary. So, classical echo pattern. In another case, with 13-year-old female with suspicion of appendicitis, and no appendicitis here, but we found the gestational sac in the uterus. It's an early pregnancy. Another child which is with suspicion of appendicitis, and there is no appendicitis here, only hydrothorax and both sides pneumonia. It's a 7-year-old child. Another case of trauma, it's intestinal contusion, hematoma with omentum infarction, and teenager falling from the bike by the abdomen onto the handlebars. We can see pseudokidney sign, gyparechoic omentum around, thickened wall, spasmodic intestinal loops. Another traumatic case, child falling off the ramp, and we can see the spleen with diffuse changing of its lower third, with border clearly seen, and blood flow decreasing in this area. Another case, it's a kidney rupture, paranephric fluid collection, blood. It's a patient 17 years old, which punched in the indicated area. Okay, another case, another strange case with child with suspicion, 4-year-old child with suspicion of appendicitis, and no appendicitis here, but there is a abnormal vessel with venous spectrum of blood flow at pulse wave Doppler. Another trauma case, child from the car accident, hit by a car and crossing the road, and at ultrasound and MRI was found that anechoic structure in the hilum of spleen and pancreas tail, presumably hematoma, retroperitoneal. Another case of 6-year-old female child with suspected appendicitis. There is no right, we can see left ovary on the typical place. We can see right ovary, but we can see the big cystic structure above the bladder, and this cystic structure has a leg that descends to the right side. So this is the ovary, the right ovary, the torsion of the right ovary. Another example, it's a teenage girl with cachexia and complaints of pain below the umbilicus in the abdomen, in the midline. Clinicians suspect appendicitis, but we found the big amount of free fluid, ascites, and some strange gyparechoic lesions, disseminates of the peritoneum, pseudokidney. Very sad. Thank you. That's all.